All right, so this is the portion of the program where we do questions and answers. So I would like to ask all of our speakers to come join us here on a very colorful stage. Maybe Brenda can help us find some seats available. Not that one. All right, ready or not, here we go. So thank you very much for those of you that submitted questions. If anyone would like to have something answered, we've still got about 12 minutes here. So we'll start with Dr. Larry. Regarding physicals and tests, one of our audience members has asked, how often should men see their GP for a physical at various ages? What checks or tests should be done at each age group? Could you comment?
So there is a checklist. I think I brought some. They're out at the front.
Okay.
Of different tests that you should be aware of at different decades of life, so 20s, 30s, and so on. There was an interesting study recently that showed that going to attend your physician on an annual basis is not necessarily going to increase your life expectancy. If you're healthy, you don't have to go every year. You probably should go every 1 to 2 years. As you get older, though, you're getting into situations where you have so many different things on the checklist that you probably will want to go on a regular basis. But certainly in your 20s, 30s, 40s, recommend that you get at least, the baseline studies done. Say you're 40 years old, you probably should have your blood pressure checked, have a urinalysis done, check your blood sugars, know your family history, see what you might be at risk for. Colonoscopy is being recommended for screening for bowel cancer. PSA is controversial. If you have a risk factor, if you have a family history, a close relative with prostate cancer, if you're obese or Afro-American, probably should start in your 40s. It's a controversial area. It's a whole other lecture on when to start screening for prostate cancer. Do you want me to keep talking about this?
Sure.
Because prostate, once I start talking about prostate cancer, you can't shut me up. But, as we know, you don't want to wait too long for that first PSA. And there was an interesting research done in the last few years that shows if you get your PSA done in your 40s, just one as a baseline test, and if it's low, if it's less than a number called 0.5, your risks of developing prostate cancer are quite low, particularly aggressive, deadly type of prostate cancer. Whereas if in your 40s and your PSA is over 1, you actually should probably have annual screening because you're at higher risk. The other thing is that we've learned in the last few years is if you have a family history of breast cancer, then you are at increased risk for prostate cancer. And that's a genetic issue. There's a gene called BRCA1 and BRCA2. The Angelina Jolie story, having the bilateral mastectomy because she has a high risk with BRCA2. If you have BRCA2 in your family and you're a male, you're at high risk for prostate cancer and an aggressive form. So there's a lot of different factors and issues that come in to answer that question. But what I found interesting was you don't have to go exactly every year, especially if you're younger. But know what your baseline studies are.
Thank you very much. And this one's directed to both Barry and Craig on some advice. So I'd like you each to answer this one. Based on your experience, could you share one piece of advice to men aged 55-ish?
Oh, you want me to talk? Okay. Well, that would be take ownership of your health and go see your doctor, and don't avoid your doctor. And I don't know, I've heard the PSA is very controversial. I had no symptoms whatsoever. There's nothing alarming with my physical examination when Brian examined me. When I went in for the biopsy at Lionsgate, everything seemed fine. So the PSA was high, it was about 11.5, so that's when Brian got me in to go see a specialist, Dr. Hogan, Vancouver, and thank God I had the PSA checked at that point, because if I'd waited much longer. So yeah, take ownership, get your PSA done. Like Larry said, if it's in the family, it wasn't in my family. My grandfather passed away at 85 with prostate cancer, but was a complete shock to me.
I think it's important to seek out, ask questions to your doctor as opposed to trying to self-diagnose online. I know I spent a lot of time reading, looking at my symptoms and wondering, what was this and what was that, and tossing out things I didn't want to hear and reading the things that sounded positive to myself. But I think just checking out with your doctor, because I think a lot of time goes into self-diagnosis that's not necessarily the best for you.
Great.
There's a great coffee mug that says, "Don't confuse Dr. Google with my medical degree."
Excellent. And Dr. Larry, while you've got the mic there, there's a question here on surgery, and a question about, is surgery performed on people over 70 years old?
Yes.
There's your answer.
You want the long answer?
Sure?
No, chronological age isn't important. It's biological age that's important. I have 80-year-old men who are going on 60, and 60-year-old men who are going on 90. So you look at the individual. Age is irrelevant. I mean, obviously, if someone's 95 years old, you're not going to be terribly aggressive surgically. But people are living to be 100 nowadays, and if a man or a woman has at least a 10-year life expectancy, and surgery is something that is what they want, and after having done the due diligence and looking at all your options, and surgery is what you want, sure. I've operated on many 80-year-olds.
Okay, terrific. And Kate, we have one for you, and that is, in your presentation, you mentioned some resources in Vancouver. Could you mention a bit more on how someone would possibly engage with them, or how the conversation gets started?
For sure. I have a handout here. I'll grab it and put it on the table with one, the GF Strong health clinicians, the sexual health clinicians, with their contact. And I asked them, and also from the prostate center as well, the sexual health clinician, I asked them both, can I give out your contact to the community? And they said, absolutely. So their phone numbers and emails, and so you can just send them an email or give them a call and ask to meet. And I don't believe you need a referral from a doctor. I don't think so, yeah. Oh, good.
For we have a prostate, at the Vancouver Prostate Center, there's a prostate cancer supportive care program, and you do not need a referral. It's a modular program, so first diagnosis, there are education events where you listen to a surgeon, a radiation oncologist, and a patient survivor, and you have one-on-ones with the physicians. It's a very highly recognized evening. People who come there really enjoy it and find that it's very, very useful to help them understand the disease and help them towards their decision making. We have a module on sexual health that addresses prehab and rehab. So prehabilitation means educating people ahead of time, get their expectations appropriate. So, I mean, the sexual side of prostate cancer treatment is so important, and it's something that I spend a lot of time on myself. And this module will allow, we have great sexual health clinicians who will help you understand what's going to happen to you, what your options will be after treatment. And there's one on urinary control, there's one on psycho-oncology, there are a lot of people can't cope well with the diagnosis. It's not easy. So we have all of those programs in place, and you just need to phone the Prostate Supportive Care Program, and you can be enrolled.
Terrific. Okay, Dr. Larry, we have a bit of a technical one here for you, and it's entitled Birch Slings. Birch slings, how long do they usually last? Can they be repaired or redone? And if not, what is done to fix urinary incontinence?
Okay, so a birch repair is something that is a procedure done in females for stress urinary incontinence. A sling is done in men for stress urinary incontinence. So the terminology is actually you're addressing two different things. So a birch repair is actually an operation. Now, it's not done, I don't think, by anybody anymore. I mean, it was what I did when I was young, before the newer technologies and techniques are available. And it was an operation where you created a hammock from the vagina that lifted up the urethra and decreased the problems of stress urinary incontinence, which means when you cough or sneeze, you lose urine. After a radical prostatectomy, you can develop stress urinary incontinence as well because of weakening of the musculature. So it's very similar to what happens to a woman who's had multiple children. It's just a weakening of the pelvic floor. So a sling procedure is putting a little piece of mesh underneath the urethra through a small incision behind the scrotum, and it acts like a hammock. The reason that you lose the water is when you cough or sneeze, by increasing your abdominal pressure, everything falls down, if you will. So this prevents it from falling down. And it can cure the incontinence. For very severe urinary incontinence that doesn't recover, then you need what's called an artificial sphincter. And that's a much more complicated surgical procedure, but it works very well.
Okay.
But it's an implant.
Okay. We've just had a couple submitted here, and Dr. Goldenberg, if 21 ejaculations per month is the ideal, are there...
Minimum.
Never in the job description, Jerry. Are there risks of redlining at the higher rate of EPM? You started it, so...
I'm not touching that one.
Okay, and then more seriously, there's been no mention of working with boys in terms of their diet and physical activity.
Yeah.
Should this conversation be started earlier
Yeah.
in a men's health?
Great question. I can't agree more. In Italy, they have a great program in high schools for boys and teenagers, educating them on preventative health, and exercise, diet, and so on. We should do that here. I mean, and it's just another program. It's just on the list of things that need to be done. Really need here. Why don't we get a school principal to address it?
Barry, did you want to say anything about that?
Beginning Monday, we will. We are branching out so much in our schools in the field of sexual health. We have various people. A former student of mine actually is speaking with almost every school on the coast, dealing with all aspects of sexuality, starting from young grades. And some of you remember Meg Hickling, this person trained under Meg Hickling, and is just wonderful in terms of opening the door for those kinds of conversations, and promoting students to take information home and share with their families, and just move forward.
Other lifestyle behaviors, exercise, diet.
The exercising lifestyle, those kinds of things are built into the curriculum. So it used to be something called Learning for Living, then it became personal planning, then it became career and health education. And then we have a new curriculum, that curriculum sort of endorses those kinds of topics right through all subject areas.
And don't forget zipper injuries. I say that somewhat in jest, but I gave a talk at a high school once, and that was the question that came from the audience. There was a young boy who was having trouble with his zipper. Sorry, digressing. Go ahead.
On that note,
It's late. I started very early this morning.
I think that's a sign that maybe we should conclude, so thank you very much. And would love to encourage everyone to submit their surveys if you could. But thank you so much to our speakers.